Hi, my name is Michelle Lamar. I work as a registered nurse on a behavioral health unit. I've been implementing a change project that I call Standardizing Pre-Admission Assessment and Expectation Education for Behavioral Health Admissions. Along with an interdisciplinary team, we identified some challenges with the admission process to our unit, came up with a plan, implemented it, and looked at the results. In the behavioral health unit, or the BHU as we call it, there are a few significant challenges that we face when admitting patients. There's a high number of detox patients leaving against medical advice, or AMA, within 24 hours of being admitted, many within an hour. These patients sometimes have incorrect expectations of the environment to be expected on the behavioral health unit. They don't realize that they will not have their own personal electronics or that it is a locked, mixed psychiatric unit serving a diverse population, not just patients seeking medical detox, but patients with any number of psychiatric diagnoses, including bipolar disorder, schizophrenia, or manic behavior. The admission process is time-consuming, taking well over an hour to complete all the process interventions and charting, as well as getting physicians to enter orders that will allow staff to care for the patient. Once a patient's accepted, it is difficult to reverse the admission, and patients that have not been properly assessed could be admitted inappropriately. Communication between the emergency department and the BHU has become increasingly strained, and workflow has become increasingly inefficient. So these issues that we've noticed on the behavioral health unit admission process, they have led to some system-wide impacts. Patients admitted for detox that leave AMA within 24 hours have incomplete treatment that lowers their ability to succeed. If a patient is aware of what to expect on the behavioral health unit and it is not what they're looking for, they can look elsewhere for treatment more aligned with their expectations and goals. However, if they're already transferred to the behavioral health unit and then leave AMA soon after, they're less likely to have an alternate plan other than going right back to their home. This increases the risk of relapse. Patients occasionally express feeling unprepared and uninformed about where they are being transferred. The BHU has a loud environment due to a population that includes those with mania, psychosis, and even sometimes aggression. Patients endorse being unaware that they were going to this environment rather than going to a place with only other patients seeking detox. They state that they are unaware they cannot leave their unit, cannot smoke, and cannot have their own personal electronics. This leaves them frustrated and feeling taken by surprise or misled, decreasing trust and increasing the stress on the patients. When a patient is admitted to the behavioral health unit and immediately chooses to leave against medical advice, the entire admission must still be documented, which takes about an hour. Simultaneously, a discharge must be documented, which also requires several steps and documentation, even for an AMA discharge. This leads to increased workload, demoralization, and frustration by the staff. The time spent doing these admissions and discharges simultaneously takes away from caring for the other patients or admitting a patient who needs treatment provided by the behavioral health unit. This affects staff productivity and even the safety of the milieu. Overall, AMA discharges lead to costly readmissions and poor outcomes by patients, as supported by a study by Tan, Feng, Joyce, Fisher, and Mastagami. Having multiple patients admitted and then discharged against medical advice without essentially getting any treatment at all is an inefficient use of resources and beds. Our theory was that the more informed and prepared a detox patient was, the less likely they would be to be dissuaded by the reality of the rules on the unit, and they would instead be more likely to stick to the program and increase their chances of success. Of course, when a patient briefly takes a bed on the behavioral health unit and then leaves, that does cause a delay for other patients seeking treatment. The lack of consistent admission criteria and exclusionary criteria creates confusion and a disconnect between the emergency department and the behavioral health unit. This causes the relationship to become strained when staff on the behavioral health unit get frustrated, feeling like the patients being admitted are not being informed or appropriate, and the emergency department staff that maybe don't have clarification on the criteria and process feel like the behavioral health unit are avoiding or delaying admissions. So I did a structured literature search for evidence related to screening, patient education, communication gaps, AMA discharges, and other things that were related to the problems that we are trying to intervene. I searched CINAHL, PubMed, PsycInfo. I used keywords such as against medical advice, psychiatric admission, screening tool, and patient education. I included articles that were specifically discussing adult inpatient psychiatric or emergency department populations, and that evaluated interventions related to screening, education, and communication, especially if they discussed AMA discharges. I excluded studies focused on outpatient settings, pediatric populations, non-psychiatric units. All articles were from the last 6 years. An article by Tan, Feng, Joyce, Fisher, and Mastagami stated that AMA discharges are associated with an increase in readmissions and are also linked to just overall patient poor outcomes for the patients. The article also mentions that patients with substance abuse disorders are actually much more likely to leave against medical advice, and I've definitely seen that on my unit. Patients can be experiencing especially uncomfortable detox, or if they feel like they're not in the right environment. An article by Simon, Snow, and Wakeman noticed that a common reason many patients being treated for substance abuse leave AMA is feeling like a locked unit is too restrictive. Another article by Batad and Pacifico found that providing educational material to patients it improves informed consent and decision making for the patient. An article by Guéry, Zalmahone, Carmichael, Uwezeye, Legare, Grimshaw, and Gagnon. They also said that improved patient education increases compliance and engagement in treatment. The idea to use standardized checklists was supported by an article by Chance, Florence, and Sardi Abdul. That article states that standardized checklists improve consistency in the decision-making process among healthcare providers. So, for example, when doctors are deciding whether to admit a patient or not, and reduces errors in that process. It also found that standardizing checklists improves communication and collaboration efforts between interdisciplinary teams. The same idea is used when hospitals promote the idea of using SBAR in giving reports. The Change Project had a couple main goals. One was to reduce the number of patients that leave AMA, specifically within the first 24 hours of admission. Based on casual observations I made over the years, in most of these cases, a lot of them were detox patients who said they were uninformed about the unit. They were very dissatisfied with the rules, specifically not having access to outdoor time to smoke, not having access to their own personal electronics, and having a roommate rather than a private room. Some even said that they were unaware they were going to a psychiatric unit with patients who were there for manic behavior, schizophrenia, and altered thought process. These are all things they were not informed of in the emergency department when deciding to make the decision to be admitted for detox. Our goal was to ensure these patients were informed of what to expect so they could mentally commit to the program. We also set out to make the screening process for all patients being considered for admission a little more standardized and consistent. We wanted to educate the emergency room doctors and nurses about a few exclusionary criteria that would indicate a patient that the BHU was not equipped to treat. One example is a patient requiring a CPAP machine because all electrical outlets have actually been removed from the patient rooms on the behavioral health unit for safety reasons. We also wanted to educate and clarify what constituted criteria for inpatient admission. We wanted to create a process that would improve communication between the BHU and the emergency department so that the decision-making process was more consistent and relevant information was given to the on-call psychiatrist that it was accepting the patients for admission to the behavioral health unit. Our project is being completed at Spotsylvania Regional Medical Center, an HCA hospital in Fredericksburg, Virginia. Specifically, it's being implemented on the 28-bed locked inpatient behavioral health unit. This unit serves as a mixed population that includes those seeking medical detox from opiates or alcohol, as well as many other psychiatric conditions. There are patients there for stabilization after a suicide attempt or having strong suicidal ideation, as well as patients presenting with active psychosis and occasionally even aggression. This makes for a stressful environment at times, despite all staff's efforts to keep the environment calm. Every patient must receive medical clearance in an emergency department, which includes a physical exam, complete blood count, complete metabolic panel, a urinalysis, a drug screen, blood alcohol level when indicated, and a pregnancy test for women of childbearing age. This unit serves an adult-only population of 18 to 70 with case-by-case consideration of adults over 70. Each patient must be evaluated and medically cleared by the hospitalist to evaluate for medical concerns that may supersede the patient's psychiatric concerns. The patient is usually evaluated by an independent psychiatric team, usually via telehealth, to determine if inpatient psychiatric admission is the best plan for the patient, or if their needs can be met with a home safety plan and outpatient follow-up. The psychiatrist on call is then notified and makes the determination to accept the patient to the behavioral health unit, and the emergency department doctor then places an order to admit the patient. Most of the time, the patients are interested in seeking help. If inpatient treatment is recommended to them and they decline, there is a process in place to have the patient evaluated for temporary detainment order to place them involuntarily if they're truly seen to be a danger to themselves or others. However, my project was focused on patients who were admitted with a voluntary status and left against medical advice on the behavioral health unit soon after admission. There's a high demand for beds, and sometimes patients in the Spotsylvania Medical Center's emergency department will wait a long time to be transferred to the behavioral health unit. And sometimes they will be sent to alternate facilities when there are no beds available in the behavioral health unit at that hospital. Likewise, Spotsylvania Medical Center's behavioral health unit often gets patients from other hospital emergency departments. The institutional sponsor I worked most closely with is Robin Dameron, RN BSN, and the nurse manager and acting interim director of the behavioral health unit. Marianne O'Brien, RN BSN, who is one of our frequent charge nurses and a clinical nurse coordinator, also collaborated with me on the project. They both worked with me in developing the checklist and pamphlet that we will discuss more about later. For the Change Project, I referenced the Plan, Do, Study, Act, or PDSA change theory, which is a structured way to evaluate changes and interventions continually. PDSA is a framework that allows for constant improvement and refinement of interventions and processes. First, we developed a plan. We identified 2 problems, which were detox patients leaving AMA within the first 24 hours of being admitted, and the second problem addressed was patients who did not meet criteria for admission coming to the behavioral health unit, as well as exclusionary patients we were not equipped to care for. We then developed a strategy to use 2 brief interventions. We developed a checklist and an informational pamphlet to be given out to potential behavioral health unit patients being medically cleared in the emergency room. Then we began implementing it by using the checklist to quickly evaluate if there were exclusionary criteria for patients waiting in the ED or if the patient did not meet criteria for admission. We did distribute the pamphlets when assessing patients in the emergency department. The use of the checklist and the pamphlet was inconsistent, especially when I was not working, but I made notations on 8 patients that had been screened using the checklist and 4 patients that I was aware of that would have benefited from having the checklist and pamphlet used. In the study phase, I've looked over all the information to determine whether the intervention was helpful. The results indicated that if used consistently, in other words, made into policy, there would be a benefit. We're currently in the ACT phase. We're considering if there are other changes that need to be made to the interventions and how to increase education and consistent compliance. PDSA is an ongoing cycle for refining interventions and processes continually. To implement the project, 2 supporting documents were created. First, a checklist was created to work as a brief screening tool to ensure that admissions were appropriate for the behavioral health unit. The checklist was intended to be used before the patient was accepted by the admitting psychiatrist. It lists the criteria needed for admitting a patient to the behavioral health unit. For the most part, we are looking to know whether a patient's needs could be met with a safety plan and outpatient referral, or if the crisis does indicate that the patient should be admitted to the behavioral health unit for their or others' safety. It also lists some exclusionary criteria that indicate that the behavioral health unit is not equipped to meet the needs of a particular patient. The pamphlet was developed as a brief educational tool to give to the patients in the emergency room that are possibly going to be admitted to the behavioral health unit. It explains to the patients what the behavioral health unit offers for treatment. It also includes an important section describing the safety measures that are needed for the unit and what items are and are not permissible for use on the unit. The purpose of the pamphlet is to manage patients' expectations and to avoid any confusion regarding what the behavioral health unit is and what their treatment will look like. Here you can see the checklist on the right. It was developed with the intention of being used before a patient's acceptance by the on-call psychiatrist. It also was developed with the intention of being easily used by the emergency department nurse caring for the patient or a behavioral health unit staff member. We'll talk later about intention versus what actually occurred. It is meant to standardize admission criteria and exclusionary criteria for the emergency department staff who may have varying levels of familiarity with the behavioral health unit. One important thing you see on the checklist is the need to first clarify if the patient is voluntary for treatment or not. If not, the emergency department physician can either release the patient against medical advice or ask that the patient be screened for a temporary detainment order in order to be admitted involuntarily. As the behavioral health unit is not staffed to give full care to patients, they must be able to complete all their own activities of daily living. As you see, there is a section listing exclusionary criteria, and to be admitted to the behavioral health unit, it is important that none of these apply to the patient, such as having been physically violent with healthcare workers within the last 48 hours, or if they have a cognitive impairment that won't likely change with treatment or gain benefit from the behavioral health unit's program. It does have a section to ensure that the patient has been made aware of the restrictions on the behavioral health unit in order to manage their expectations, as on admission, patients have frequently endorsed not being aware of exactly what kind of environment they had agreed to be transferred to. The checklist was designed to be a quick screening tool that would only take about 5 minutes to answer a handful of yes or no questions for clarification and smooth workflow. Here is the pamphlet developed to give patients that are in the emergency department that are possibly going to be transferred to the behavioral health unit. It is a tri-folded pamphlet, and this page serves as a sort of the outside. On the far right is the cover, and on the very back will be the contact information as seen in the middle. The far left is what will be immediately visible after opening the cover, and it simply gives an overview of what we treat on the behavioral health unit. Much more information is on the inside part. The inside of the pamphlet can be seen here on the right and contains the bulk of the information about the unit. It discusses more about the behavioral health unit program, what services the patient can expect to receive, and it also sets the expectation for a 5 to 7 day stay. Some patients arrive to the behavioral health unit thinking it is overnight, see the psychiatrist once and then go home kind of program, and some are expecting a 30-day substance abuse rehab. The pamphlet lists several things that some patients are aware of when coming to the unit, as you can see in the middle section, as well as what items are allowed and not allowed on the unit. We listed them in the column as don't bring and bring in another column so that it didn't appear so much as a negative or warning. It's important to educate the patients about these things because being uneducated about what to expect and what is not allowed is one of the most common reasons that patients request to leave an AMA as soon as getting on the unit. One major point of this project is to reduce the frequency at which that happens. It lets the patient know who will be treating them and who they will be interacting with during their stay. We have a wonderful team of registered nurses, psychiatric nurse practitioners, activity therapists, and social workers that all come together for the patient's care. It also gives a brief list of what the patient can expect their day to look like. So let's talk about the implementation of the project. The timeline of March 13th to April 13th was set aside to implement the new workflow. Ahead of that, there were discussions between myself and my institutional sponsor, which is the nurse manager of the behavioral health unit. She also met with the emergency department leadership and the chief nursing officer to discuss the proposed checklist, pamphlet, and workflow. The intention was that either an ED nurse or behavioral health unit staff would screen each patient with the checklist and give them the pamphlet. Then the patient would be presented to the on-call psychiatrist for acceptance. At the time of screening is when the patient would be given the pamphlet. Unfortunately, the workflow and documents were not officially adopted by the emergency department. Behavioral health unit then took responsibility for being aware of the patients in the emergency department that were potentially slated for transfer to behavioral health unit and going down whenever possible to assess them and give them the pamphlet. However, even among the behavioral health unit staff, use of the documents and gathering of data was inconsistent and informal. So data collection was much less formal than intended, but when I did go to assess a patient in the emergency room, I made a notation in a Word document. I also made a notation when another behavioral health unit team member did so, and I was able to discuss it with them. When I assessed patients in the emergency department, I used the checklist and provided a pamphlet. Along with the data assessed, I noted the patient's response to the education I gave them about the unit. We'll discuss that more momentarily. But I also noted any patient I was aware of that left AMA within 24 hours of admission, as well as what caused them to decide to leave AMA, if I could get that information. I also made a note of any patient I was aware of that had been admitted that said they were misinformed or uninformed about the type of unit they were going to or some aspect of the behavioral health unit environment or rules, even if they did not end up leaving AMA. I also made sure to make a note when a patient was admitted and then was found to have met exclusionary criteria, or they did not meet criteria for admission. An example would be a patient not having suicidal ideation or other strong reason that they would be unsafe in a less restrictive environment. We will discuss the barriers encountered in a moment, but here's an overview of the results of what I was able to document. During the pilot period of March 13th to April 13th, I worked 12-hour shifts, and the data collected does not represent every admission during that time frame. The majority of admissions we get are appropriate, and the patients stay well over 24 hours. I was more focused on any admissions that were most pertinent to the problems that I had observed over the years. I noted 26 admissions that I had either been involved with or made aware of. I myself, during that time, had gone down to the emergency room and assessed 13 patients. And here are some of the numbers pertinent to the Change Project. They're all from patient encounters during that pilot month period. 6 patients left against medical advice within 24 hours of being admitted to the behavioral health unit. 2 of these discharges were directly related to being uneducated or misinformed about the type of unit or the restrictions on the unit, and their expectations did not match the environment. Some of the other reasons for leaving against a medical advice within 24 hours had to do with uncontrolled withdrawal symptoms or patients not there for detox who simply decided they didn't want to stay and did not meet criteria for a temporary detainment order. 2 patients in the emergency room for detox declined admission after being educated about the unit's purpose and restrictions. In all, 3 patients clearly expressed having different expectations of the unit due to not having been given thorough information. 3 admissions were identified that could most likely be classified as inappropriate. 2 patients had to be transferred to medical within 24 hours due to having medical needs or crises that were unable to be safely or properly addressed in the behavioral health unit. This included a patient reported to have a CWA of 8, but after arriving on the unit, he was found to be extremely confused and actually scored a 19 on a CWA due to the confusion and other significant symptoms. Protocol says that for a patient's safety, a patient having a CWA of 15 or higher needs care on a medical unit for safety, such as they might need IV medications. One person in the emergency department who didn't want to come was assessed by behavioral health unit staff for possibly not meeting criteria for admission, but he ended up being screened and put on a temporary detainment order, but then he was released from his hearing the next day. The findings I recorded suggest that a lack of education and unmanaged expectations do contribute to early AMA discharges, while clinical workflow factors were the cause of others. So this chart is breaking down 26 admissions that I examined. There was a total of 129 admissions during the pilot period. But the ones that I examined, the 26, included all patients that had been screened, all AMA discharges within 24 hours, and all of the cases that potentially were not an appropriate admission. I screened 13 patients. None of the screened admissions ended up leaving AMA within 24 hours or were found to be inappropriate. 2 of the screened patients declined admission after receiving education. And among the admissions that I reviewed, 6 patients total left AMA within 24 hours. None of them had been screened, and 2 of them definitely said that the reason they were leaving was that they didn't like the rules or the environment on the unit. So the exact things that we're trying to fix with our interventions. 4 of them left for other reasons. 3 patients did say that they had not been informed about the unit. And in total, 3 admissions were inappropriate admissions, and screening helped to prevent 2 likely AMA discharges, the ones that declined to be admitted, and 1 inappropriate admission. Now let's take a look at what these results show us. There's evidence that when education is given to patients, they have better understanding and increased informed consent when they decide to be admitted. There were cases where the interventions, meaning educating and screening the patient, did prevent inappropriate admissions. One patient was told he could not have his electronics on the unit, and he said because of his work he could not be without his laptop. He thanked me for letting him know ahead of time, and he declined admission. This probably prevented an AMA discharge soon after admission if he had have been admitted. Other times, patients expressed their understanding and accepted admission with more managed expectations. However, in 4 out of the 6 AMA discharges recorded, education either did not or would not have prevented the reason behind leaving. And this shows that other clinical factors must be explored to reduce the number of AMA discharges from the behavioral health unit. Only 2 AMA discharges were directly due to patient expectations being unmanaged because of lack of education. But the interventions were used pretty inconsistently. This both affected the admission process, but certainly affected the ability to gather all necessary data. And it also meant that the interventions were less effective than they could have been. There were still gaps in the screening that led to some inappropriate admissions, such as a patient coming to the unit that had not been screened, and he didn't fully meet criteria for admission, which led to an AMA discharge within 24 hours of coming onto the unit. There were some pretty significant barriers to using the checklist and distributing the pamphlets to all patients, appropriate patients in the emergency department. The checklist isn't part of the EMR system as an intervention. There was definitely no official policy made requiring the use of the checklist and pamphlet, despite us meeting with the chief nursing officer and the emergency department management. So there was no enforcement or auditing to see if other staff members were using the new interventions. There was pretty limited training. There was an email sent out by my manager and institutional sponsor, and there were some staff huddles meetings on the behavioral health unit, but there were no formal educational meetings that would reach every staff in the behavioral health unit and all nurses working in the emergency department. This all led to very inconsistent use of the interventions and affected the ability to collect accurate data, which makes it difficult to truly measure the effectiveness of the intervention. Both the behavioral health unit and emergency department have very busy, hectic environments. Some of the feedback I received from staff on my unit is that the tools and screenings would be helpful, but behavioral health unit staff just doesn't always have the time to go down and see every patient there for psych or detox in the emergency room. While we're busy on the behavioral health unit, we aren't always aware of patients in the emergency room that are there for psychiatric or detox, at least not early enough in the process to allow us to evaluate them before they're accepted. The new interventions weren't adopted by the emergency department staff, and this meant that the behavioral health unit staff were in charge of completing the interventions rather than an interdisciplinary effort. I received other feedback from my coworkers as well. They acknowledged that the interventions would be helpful to avoid AMA discharges in some cases, but being that most of our admissions are for people who definitely meet criteria and definitely want to be admitted, they felt that maybe these interventions weren't appropriate for every behavioral health unit patient in the emergency room. The barriers I encountered and the results did suggest that improving consistency and making the intervention part of the workflow would improve outcomes in the future. So how can we make these interventions more consistent and effective? First, it would be ideal if the checklist were part of the electronic medical record, rather than a paper like we were using. It could be a process intervention that is required to be charted before presenting the patient to the psychiatrist. What most of the barriers boiled down to was that the intervention was not official policy. If it became official policy, the intervention would be more consistently used. Ideally, the emergency department would make a simple phone call to the behavioral health unit, letting them know of any patient that's there for psychiatric or detox reasons. And in that phone call, they could discuss the results of the screening checklist. This would give behavioral health unit a heads up and allow for coordination between the two units. Education is something that also needs to be definitely more standardized between the nurses in the emergency department and the behavioral health unit staff. There should be mandatory in-services where the intervention is discussed. Until the policy and interventions are well established, it could be reiterated in staff meetings and staff huddles. And of course, new staff orientation would also be include education on the intervention. To make it part of the official policy, there would need to be audits done to track compliance. This could be done by the behavioral health unit staff that takes report when a patient is coming up to the behavioral health unit. They would verify that the checklist had been completed and that the patient had been given the educational pamphlet. They would keep record of when it had not been done so that emergency department staff could be given further education, and we could look more into what barriers are preventing that from happening. The checklist and the pamphlet would also have to be extremely accessible. Having the checklist in the emergency electronic medical record would accomplish that. That way, it's right there in the computer, and there's no need to spend extra time to look for a paper form of the checklist or to ensure that stacks were available at all time. The checklist itself could also be simplified further. As we mentioned, there need to be more training for emergency department staff on use of the checklist and pamphlet. We are currently looking at doing a brief cross-shadow program where some of the emergency department charge nurses shadow up on the behavioral health unit for a shift and vice versa. This would improve the strained relationship and would help each department better understand the other's procedures, protocols, and workflow surrounding getting psychiatric and detox patients admitted to the behavioral health unit. And that way there could be more collaboration in how to better implement these interventions. All staff would need to be educated on the reasoning behind the checklist and which patients it's most crucial to complete it for. The importance and benefits of the pamphlet and education that ensures informed consent could also be reinforced. When people understand why these interventions are important, then compliance will increase. During the Change project, we identified a couple problems with the behavioral health unit admission process that led to patients leaving against medical advice within 24 hours of admission and also led to some inappropriate admissions. We learned that patient education improves patient satisfaction and outcomes by increasing understanding and informed consent. We developed a couple tools, a patient educational pamphlet, and a brief screening checklist in order to assure patients being admitted to the behavioral health unit were appropriate and informed. We did see that some AMA discharges could be avoided with the patient screening and educational materials. But we did learn that not all early AMAs are a result of patients being unaware of what to expect on the behavioral health unit prior to being admitted. Other areas of workflow and environment need to be addressed to significantly lower the number of AMA discharges. During the implementation phase, there was inconsistent use of the interventions due to some barriers such as busy workflow and lack of standardized training. If these interventions are to be effective, there needs to be a more standard policy and more consistent implementation. Ultimately, this project shows that simple interventions can improve patient outcomes, but their success depends on consistent integration into everyday clinical workflow.